gestational trophoblastic disease and moles are the same thing. I want you to separate benign moles, that is the complete molar pregnancy and incomplete molar pregnancy, from malignant moles, that is invasive molar disease and choriocarcinoma, recognizing that all of them constitute gestational trophoblastic disease. The malignant ones are gestational trophoblastic neoplasia. Lots of vocabulary there you don't really need to know. Let's talk about the stuff that you do. To start, let's talk about a normal fertilization. In a normal fertilization, an egg with its full genetic complement is going to combine with the sperm with its genetic complement and form a normal zygote. Half egg, half sperm. In a complete mole, this same pattern happens. An egg comes together with the sperm, except that the egg is broken. So when the combo forms, it's only got half the complement. Well, the zygote doesn't like that, so what happens is the sperm simply doubles its complement. And you get a zygote that has a normal genetic complement, but consists of 2 sperm sets, which doesn't make a real thing. So you're going to get a complete mole, sperm-sperm. A complete mole is completely molar. There are no fetal parts, which makes sense because there's no egg portion. It's just a bunch of DNA. And it is completely chromosomal. That is, it has a normal complement of 46 chromosomes, even though they're the wrong ones. And it is completely spermal. A product of a good fertilization and a bad egg. Now, these things happen to grow really fast, and that's the thing that's going to tip you off. The most common presentation of gestational trophoblastic disease is vaginal bleeding, but vaginal bleeding has a really big differential. So what you should look for are the signs and symptoms of the molar pregnancy growing too fast. Look for things like size-date discrepancies. It's too big, too early in the pregnancy, and a very elevated beta-HCG. These can get up to over 100,000. Because of that elevated beta-HCG, which looks like TSH, you might end up with some hyperthyroidism. And all that beta-HCG might cause hyperemesis gravidarum. Hyperemesis gravidarum is morning sickness, but at a superlative level. It's not just a little nausea and vomiting, it causes dehydration and electrolyte abnormalities and may persist into the second trimester. If you do a physical exam and look into the vagina, you'll see a grape-like mass. That grape-like mass protrudes through the cervix. And because of all that beta-HCG, you might actually get a benign adnexal mass. It's a simple cyst. The diagnosis of a molar pregnancy starts with a transvaginal ultrasound. And this is the board favorite. Transvaginal ultrasound shows a snowstorm pattern. You see snowstorm pattern, it's a molar disease, you're done. The best diagnostic tool is also the treatment step, and that is to do a suction curettage. DNC is generally not the right answer unless it's in the second trimester, or you're doing it to try to scrape out residual tissue. But you're not done once you've removed it. And by removing it, you'll see the grape-like mass come out of the uterus. But you're not done. When you diagnose a molar pregnancy, what you need to do is follow the beta-HCG, usually every week for a year, while being on reliable contraception. OCPs are generally recommended, but you can choose any reliable contraception. And the reason we do that is this. This is the beta-HCG level. This is time. As you remove the tumor, what should happen is that beta-HCG level should fall to 0 and stay 0. If at any time it begins to rise, you're worried about invasive disease. This is choriocarcinoma. Going down to normal or negative is what you expect. But you don't know if this rise in HCG is from a pregnancy or from invasive molar disease if the person can get pregnant. So you keep them on reliable contraception so that if the beta HCG rises, you know it's malignant disease. We'll get to this in a minute. If you understand complete mole, incomplete mole is really simple. So if you don't fundamentally understand it, pause the video, go back, watch it again, understand complete molar pregnancy. Because incomplete molar is almost the same. Incomplete moles arise from dispermy. An egg ends up getting fertilized by 2 sperm. This, by definition, causes an abnormal genetic complement. So the pathology of an incomplete mole is that it is incompletely molar. There are fetal parts, a product of the egg. It is incompletely chromosomal, generally presenting with 69 chromosomes. And it is incompletely spermal. The egg is there. It is caused by a good egg, but a bad fertilization. And this is why I said it's really easy to understand incomplete mole. The patient presentation is the same as complete mole. The diagnostic step is the same as complete mole. The treatment is the same as complete mole, including the follow-up with serial HCGs and contraception. If you have that rise in HCG and you're on oral contraception, that is the indication that you now have an invasive molar disease, invasive gestational trophoblastic neoplasia, or choriocarcinoma, which I'm just going to call simply chorio. Chorio is malignant, and it is a product of gestational contents. It is a gestational trophoblastic neoplasia. The patient is going to present with symptoms of elevated beta HCG. So it's going to be very similar to molar pregnancies, and it can occur after a miscarriage, a molar pregnancy, or a normal pregnancy. And those that occur after normal pregnancies have the worst prognosis simply because that's not supposed to happen. Very similar to a complete or incomplete mole, the first step is going to be a transvaginal ultrasound. The best test is a biopsy obtained by getting a curettage. After you've made the diagnosis, you need to stage with some sort of imaging, generally a CT scan. And choriocarcinoma likes to go to the lungs and the brain. The treatment is going to be both surgical and chemo. And making this decision is actually fairly complex based on the stage. The staging and recommendations are in your notes, but that level of memorization probably isn't worth the squeeze for the test. So this is what I want you to take away. You're going to have both surgical treatment and medical treatment, which means chemo. The surgical treatment can be a total abdominal hysterectomy for localized disease to the uterus, whereas surgery is going to be a sensory debulking disease for more advanced disease. Medical therapy can get into really aggressive chemo, which I don't want you to remember, but what I do want you to learn is MAC, because even the chemotherapy regimens are based on methotrexate and actinomycin D. Essentially, everybody is going to get methotrexate and actinomycin D. Some patients are going to get cyclophosphamide. Some patients will get additional chemotherapy on top of methotrexate and actinomycin. Everybody gets methotrexate and actinomycin. Refractory disease gets cyclophosphamide. Advanced disease gets more chemo that has a methotrexate and actinomycin backbone. So what I want you to see is that complete and incomplete moles are the same thing except based on their pathology. Look for the rapidly growing and elevated beta HCG symptoms, diagnosed with ultrasound, and once you cut it out, make sure they stay on OCPs and get serial HCGs. If the beta HCG begins to rise, think about chorio, repeat your transvaginal ultrasound to see it, suck it out to make the biopsy, and then stage it. And again, the treatment is either going to be some sort of resection or methotrexate and actinomycin D backbone chemo. That is gestational trophoblastic disease.